Hello, everybody. I'm Matt White. I'm the Acting Director of Behavioral Health and the Medical Director for Psychiatric Services. Thank you very much for coming this morning to our third behavioral health report out, our second report out related to a rapid improvement event. As many of you know, these are just my absolute favorite weeks of the job. It's a chance to step away from the day-to-day and really take a look with a big aspirations, big hopes, a lot of people from across the system with a diversity of experience in many different aspects, from those with lived experience, family members, and people that work in many different parts of our system. And to just get all these people together in a room and think big and think about how to make the system better. By way of some background, as many of you know, we had a value stream mapping in June of this year, and among the things we learned about our very complicated system is that it's very complicated, and that there's many barriers to getting care. Some of them very clear, like psychiatric appointments being available, many of them structural and institutional. And building on that, we had our first rapid improvement event in September, focusing on that first visit, because we learned in our value stream mapping event that that first visit was not a useful visit from the perspective of someone seeking care. It was really a screening visit. So in September, we focused on making that visit a high-value visit, meaning a visit where you met your psychiatrist and also where you met a therapist and where you were offered a menu of services that could be available to you in that clinic and access or request those clinics, those services at your first appointment. This week, we're looking at something. How do you get to your services? How do you get to that first visit? How do you get to substance use disorder services? There's a long and winding pathway to get there. In fact, there's many different portals to entry, including the behavioral health access line, inpatient unit, psychiatric emergency room, Miller Wellness Center, jail, the streets, shelters, lots of different ways people enter into our system and touch our system. It can involve multiple conversations, multiple phone calls, messages left, callbacks, leaving lots of opportunities for delays, for just missed connections, and lost opportunities for people to enter into service when they're ready for it. So the focus this week, broadly, was on screening and scheduling for mental health services and for alcohol and other drugs services. Screening, we're looking at what does screening look like? Can it happen at multiple different types of sites? Do you need to go through the access line? Even if you're somewhere where it's a no-brainer that you need to be seen in our specialty mental health clinics like 4C or maybe Miller Wellness Center, do you need to go through the access line, or can you figure out a way that people can get screened right then and there and go directly and get scheduled for an appointment in the clinic? In terms of scheduling, we looked at visibility. Are schedules visible to people across the system? Are they even visible to the own physicians or accessible to the own physicians and providers that are providing care? And who has access to that schedule? We want to make that a lot easier to get someone scheduled, both for mental health visits and to get people quickly and easily into alcohol and other drug services. We also realized that there's generally a poor understanding both within and outside of our system of the kinds of services we offer, where we offer them, and how to access them. And this is people within the system. I've been doing this for 7 months now, and I'm still learning how to get from A to B. And if you're someone in need of services out in the community, wow, that's really hard. So this week has been a great week. There's been moments of inspiration. Dr. Radhakrishna coming up to me on a 5 p.m. and saying, "What do you think about online CBT? And can we pilot that tomorrow?" Or Anna Roth coming and saying, "Why don't you offer anyone an appointment that wants one?" It's been moments of real grounding, of Darlene Scruggs, NAMI volunteer, really making it very clear on our first morning together that It was about something more fundamental. It was about trust, and that we have to establish trust. There were moments of clear-sighted clarity. Chris Farnatano sitting down and very coolly and rationally explaining to me how to figure out a staffing plan for my clinics. Like, wow, that's really good, that makes sense. And of perspective, NAMI volunteer Ana Torres telling me about her experience in the clinics. And as we're learning about same-day drop-in clinics, to say she's been there for a long time, seeking help for one of her loved ones, and yet she didn't know that you could drop into the clinic. And so if someone as involved, as educated, didn't know what services were available within the exact clinic that person has had a lot of experience, that's grounding for us as well. So I'm excited to present the work that we did this week. There was a lot of big new ideas. There are some small, quick wins. There's a lot of hard work yet to do ahead, including a lot of trust yet to be gained. But I hope you'll be encouraged by what you hear today. Thank you.
Hi, I am Kirsten Hare. I am the family support worker at the Central County Adult Mental Health Clinic, and I'm also a family member. So I'm here to talk a little bit today about our opportunities to kind of embed ourselves in the community and really get a lot of perspectives from a lot of the individuals who interface with our system, both staff members, family members, and clients. So the access line, which is really like a call center where you can get screened for services, is not well understood. We learned this, a staff member described it by saying it's like telling someone you are hungry and having them tell you that they'll call you back. Another staff member explained in reference to the backlog that they experience a lot of times at the access line, that once we are behind, that we're really drowning. But once a person is able to connect with clinicians, we're finding that the clinicians themselves are really great. Likewise, this is kind of the experience that we've heard about the behavioral system as a whole, that it's complicated and difficult to navigate. One person that we spoke to this week said there's a lack of understanding of our system within our system. God forbid you're on the outside. In speaking to one of our family members who was advocating for a loved one within the system, they said that they called 211, called another number, got frustrated, and hung up.
Hi, my name is Adam Down. I'm the Ethnic Service Manager at the Behavioral Health Division. I was a team lead this week, and I'm also a Change Agent Fellow this year. The anecdotes and stories from our clients and staff indicate that the access line, the primary point of entry for behavioral health services in Contra Costa County, is impacted by demand, and the data backs this up. The slide presented here indicates that of the approximately 500 referrals from primary care providers received by the access line, between 70 and 90% of them are not connected to care within 10 days. This does not meet the expectations of our regulators, ourselves, or most importantly, the people we serve. The lack of capacity to meet the needs in the moment has profound consequences. In this slide, the gold line on top demonstrates the monthly referrals from primary care providers, who are often called back by access line staff. Unfortunately, approximately 40% of the time, these referrals are unable to be reached by phone. In fact, only about 1 in 5 are ever offered an appointment, and less than that actually make it to a clinical visit.
Good morning, everyone. My name is Sana Torres. I'm a volunteer coordinator for NAMI. NAMI, we're the National Alliance on Mental Illness. And what is our vision? Our vision is to empower all of us to reach our full potential through the co-design and accessible and a timely, respectful, and safe, and the spirit for wellness and hope and resiliency and a recovery for all of us. On a personal note, I'm a family member, and I appreciate the opportunity of being here, not just as a NAMI coordinator, because I was able to have my input as a family member and as the insight from NAMI to know the gaps that are not being reached. So thank you so much for all of you to be here.
Good morning. My name is Gerald Glöniker. I'm Program Chief for Children's Mental Health. This diagram outlines the goals and action steps we need to take to achieve the vision that Anna just presented. It was developed during the value stream process in June of this year. Circled in red are the action steps that the team fleshed out this week. Provide meaningful services during the first contact, make sure that screenings and assessments are done efficiently and that the information gathered are done, travel with the patient. Improve the use of our appointment system and streamline the process of filling open appointment slots.
Good morning. My name is Amanda Dold, and I'm the Integration Services Manager within Behavioral Health Administration. I also had the true pleasure of leading this team as the workshop leader this week. During our rapid improvement process, we followed these guiding principles. We practiced big eyes, big ears, and a little mouth, which means that we talked less and we listened more. We let go of our titles and we were all equals. We kept open minds. We said yes and instead of yes but and no. We used our voice and we encouraged others to do the same. We weren't afraid to say, I don't know, but I'll find out the answer for you. And most importantly, we dreamt big. Our method for improvement was conducting multiple PDSA cycles. PDSA stands for Plan, Do, Study, Act. We planned for our test based on a desired outcome. We then did the test. We studied the results and then we acted. We either made small changes, we adopted the improvement as is, or we abandoned the change altogether and tried a new PDSA cycle. You're going to hear more about these exciting tests from our team members throughout this presentation. It is no coincidence that our rapid improvement event coincided with the successful landing of the InSight on Mars this week. Just like NASA, we were dreaming big all week. Our guiding light in our explorations was the concept of trust. Our team member and NAMI volunteer, Darlene, encouraged us to consider the important foundation of trust in all of our interactions this week, as well as we move forward and dream big to redesign our system. Our team also explored the tension between making small changes versus a complete overhaul of our system. We really discovered the wisdom of doing both. You're going to hear how we made many small yet impactful changes, all while holding space for our big dreams for the future.
Good morning. My name is Matthew Liu, and I'm the Deputy Director for Behavioral Health Services. Thank you so much for the opportunity to be here and for the team to share the work of the that we have presented for you today. Our behavioral health clients come in contact with various programs and in different parts of the region of the county. For example, Cali House, a youth shelter, psychiatric emergency services at the county hospital, and Martinez detention. This week, the team went out to the various programs and interviewed clients, family, and staff in order to find out what really works and also to look for opportunities for improvement. The team has gained invaluable information from these site visits. We were able to implement some immediate action this week and also as well as collecting ideas for future improvement. Thank you.
Good morning, I'm Steve Blum, Supportive Housing Manager in Health, Housing, and Homeless Services. So in order to best address access issues, we formed 4 redesign teams. They are a streamlined screening team, alcohol and other drug integration team, standardized scheduling team, and education team. And the members of those teams are now going to share details of that. Thank you.
Good morning. My name is Katie White. I'm the program manager of the Behavioral Health Access Line, and I'm going to kick us off by starting about our streamlined screening. So the problem statement of the screening team is that clients have to wait to be screened. They have the courage, they're motivated, they're ready, and yet, as we see in the quote, when the client is finally ready, the system isn't ready for them. So, they might have multiple screenings before they even receive care. They might get screened at psychiatric emergency services, and then again at the shelter, once more at the access line, even before they get to their assessment appointment. And they're often asked the same questions over and over and over. So the goal is to create a smarter screening form that can be used by field staff, not just access, but to meet the patient where they're at. And with the other goal of directing referrals to services in the moment so that they can bypass access line and get the help that they need.
Good morning. My name is Darlene Scruggs. I'm a volunteer at Contra Costa Regional Medical Center, NAMI, and Support for Recovery. For me, I'm a patient and I'm a family member. Mental health services is very useful and very much well needed. When you have, when you're waiting, that's scary because waiting creates more suffering. You don't know what that patient is going through at that time. You don't know what that person is going to do at that time, and thinking, well, I don't know what my mental state is going to be like in an hour from now, or 15 minutes from now, or heck, even waking up in the morning. So you got to look into that, and also looking at our providers, doing self-care, giving our providers self-care, our staff self-care, because without the staff and the providers, we would not have the help to help the patients. And then you got to think about some staff and providers get burnt out. You got to pay attention to that. And then also thinking of mental health. If mental health was that simple, we would be struggling in the first place. You got to think of that. If mental health wasn't a problem, would we all be sitting here talking about this? Think about that.
Good afternoon, everyone. My name is Eileen Lush, and I'm a behavioral health ambulatory analyst. And I was honored to be a member of the Access Line screening team. Our number one test of change was to develop a smarter screening form. And we identified our primary problem was the screening form was just too long. It was almost like turning into an assessment. Also, the form could only be used at the Access Line call center. So collectively, as a team, we revamped the form by making it smarter, removing unnecessary questions, and less redundancy. The end result was a smarter form that could be used by non-access line staff, like clinicians in our Psych ED, our primary care providers, and is now more standardized.
Hello, my name is Jill Nakamura, and I am a mental health clinical specialist at the Contra Costa County Behavioral Health Access Line. So I felt really excited and really privileged to be a part of the team that actually got to test a little pilot at Psych Emergency Services. So we realized, of course, part of the problem is that we were not meeting clients where they're at. So our test of change was to just go ahead and directly go to where a vulnerable community of patients could need those extra special services and the extra special warm handoff. So what we did is I worked directly with a clinician at Psych Emergency Services, and we tested that change. And number one, what we found is that it was really important for someone to assist in navigating the system. So part of the access line is really helping folks out in terms of navigating that system. Some of you may or may not know that Medi-Cal has a lot of very nuanced rules, and some of that can come down to acuity. And so what my job then became was based on insurance and eligibility and acuity to then provide the best referral for that client. And so number two, what that did is the client would be leaving with a solid plan. So instead of a very vague instruction to call the access line and then potentially get into a game of phone tag with a clinician at the access line, folks were leaving with a solid plan of what their next step to follow-up care would be. And then also, I just want to say personally, as an access line clinician, going from being on the phone all day to then being in the community, having that direct care contact was really special for me as well. Thank you.
Good morning. My name is Andrea Leva, and I'm a therapist at Psych Emergency. So as Jill was just saying, the whole purpose of us being at Psych Emergency this week was to really try to set someone up with services right away, rather than kind of just referring them, which is what we've done in the past. So we were able to sit down with someone who was ready to make an appointment and start getting into treatment and just get them connected right away, rather than when they were discharged, just give them a piece of paper that would say, just follow up at the clinic or call the access line. So 4 out of the patients that we screened and that were eligible did leave with an appointment in hand. One patient that came in voluntary who was asking for help with therapy services, we were able to make a phone call to a Medi-Cal provider and help them get an appointment for future services. One of the quotes from one of the patients that we were able to speak to when we asked them what was helpful about this said, "I like how you all rushed in and gave me the need and the love." So it's really important. So afterwards, when we were done talking to everyone, we asked them, would you have actually followed up with the access line, or would you have dropped into the clinic? And 4 out of 5 people that we talked to said that they most likely would have not. It also gave us the opportunity to call family members and tell them that instead of just our usual, your person is ready to be discharged, we're going to have them follow up at the clinic or make an appointment, call the access line. We were actually able to call them and say, John Doe has an appointment on December 15th at 2 p.m. with Dr. Silver. And I think that made a huge difference for a lot of people. Thank you.
Good morning, everyone. My name is Mario Bendez. I'm a mental health clinical specialist at the Martinez Detention Facility. The problem that we identified at our facility was we had folks who had been treating for some time in our acute mental health module, who had actually had discharge dates that they would be re-entering back in the community. But once they left with a 30-day supply of medication, they'd have to call the access line for a follow-up appointment. So that's a barrier. Most of our patients, unfortunately, who are in our acute module are homeless or have other stressors in the community that prevent them from making appointments, having phones, returning calls, accepting calls. With the test change and the screen tool that was shortened and developed this week, we have the capability now of actually making appointments for our folks before they leave custody. Yesterday evening, I had the pleasure of actually giving a patient who's leaving on December 10th an actual appointment in the community before he leaves. So it was huge for our staff, our team. And we took it a step further. We're not only able to do this for folks who are leaving custody with a discharge date, we're actually able to do this at intake when people are going to be cited out. We have the capability now of accessing Medi-Cal to check their eligibility, see the schedule, and actually make the appointment for the for the patient within 30 minutes of them leaving custody. So this is fantastic. One of the quotes from our staff this week was, "Finally, we're able to do this. It's about time." Thank you.
Hi, everybody. My name is Mike Mayette, and I'm a mental health program supervisor with Healthcare for the Homeless in public health. And I was also had the privilege of being on the screening team as well. And we did another test of change, trying to address. We've been talking a lot about the gaps, the time gaps, and the kind of the repetitive phone calls, and all these little gaps where people can kind of fall through. And so, wouldn't it be great if you could just call the access line to get help when you're when you're feeling hot, as Darlene was talking about, when you're really feeling it, and not wait until tomorrow or the next day, and you could actually get a same-day appointment. So we did that, and so we had a test to change where we utilized same-day appointments, and so people would call in, get screened, and have an available slot that day in a clinic they could go to if they so choose. And thank you.
My name is Rohan Radhakrishna, and I'm the proud team leader for the screening team you just heard from. I'm also a client of the health plan. I'm also a consumer. I'm a primary care doctor in the West County Health Center, a chair of the Family Medicine and Adult Medicine Department, and one of your deputy health officers. We're all consumers in this room. And as consumers, when we want or need goods and services, we want them now. A couple years ago, my wife was working extra shifts on the weekend. I was home alone with a newborn and a toddler. My toddler was sick, I couldn't get out of the house, and I needed diapers. I could get those within 2 days by ordering them on my phone, and by paying a little extra, I got those diapers in 2 hours. When we need goods or services, we want them now, and we need to offer that to our family and community for behavioral health as well. Now, as a primary care doctor, I got a panel of 1,000 patients, many severely mentally ill, and when I placed that referral into the computer, I didn't know until this week what actually happened, and I was sad and crushed to learn that they don't get a call back for 25 to 30 days. My patients don't pick up the phone when it's an unknown number. A lot of them don't even use voicemail. They prefer text, which we're not utilizing. So we have a lot to improve on, and you saw the data. 90% of the time we are out of our regulatory compliance for timely access. So we gotta try new stuff. The iPhone introduced Siri, Amazon introduced Alexa, and we're already contracting with a company that has Alexa, an interactive voice recognition software that can do a lot of the stuff humans do, faster and sometimes even better. Take a listen to Eliza.
On a scale from 1 to 7, where 1 is not likely at all and 7 is very likely, how likely is it that you would seek help for your problems if you needed it? How would you rate your overall emotional health today compared to 1 year ago? Please say much better, somewhat better, about the same, somewhat worse, or much worse.
Somewhat better.
Okay. Based on your answers, it sounds like you could use a little extra help. We'd like to talk with you about how we can support you. We actually can get a representative on the line right now. Would that be okay?
Yes.
All right. Hold on for just one moment while we connect you.
This is not theoretical. Our health plan right now is using Eliza to contact 5,000 of our clients per month in English and Spanish for required screenings that we weren't able to do because we just had a backlog and it wasn't humanly possible. The difference is our humans call people back once, and if they don't pick up or identify that number, we lost them till they touch our system again with suffering and costly utilization in the interim. The difference with Eliza is that she will call you 5 times, and it increased the health plan's connectivity rate 10-fold. They can even handle sensitive questions like suicidality and get that fast track to a case manager the next morning at 8 a.m. to follow up on. So we know that automation can decrease wait time, reduce our backlog, and improve connections. So we have to try new things. The current state's not working. I'm proud of the successes our teams were able to achieve this week by having more people screening in more places. We were able to achieve magic in psych emergency and detention and get people those precious commodities that people don't know how to find, appointments, and leave with one in hand. So you're gonna hear another success story from Darren, and I just want you all to know that it's possible to have Behavioral Health Prime and give patients what they need within 2 hours.
Hi, I'm Emily Waters. I'm a psychiatrist that works at West County Behavioral Health and also in the West County shelters. Regardless of where a person is in the system, there's a disconnect between alcohol and drug services and behavioral health services. And while so many out there struggle with both addiction and mental illness, it's as if our systems, our services live in different worlds. When someone is ready for help with an addiction, we in behavioral health, we send them off to this other world known as alcohol and drug services, not really knowing much about where we're sending people to or what they're going to get. And while there's tremendous need, our outpatient AOD services are underutilized, and there are challenges with getting access to residential services. And as many of the people we met with this week at Discovery House and the shelter spoke to, it takes a lot to get to the point of reaching out when struggling with an addiction. And when those services aren't there, when a person is ready, it feeds a feeling that a person with an addiction is already struggling with, that society and even our mental health system does not care whether they live or die. Our goal this week, we're in service of getting those who suffer with both mental illness and addiction more readily available help, and to find ways to bring the providers of both services into one world where those struggling can find help when they need it most.
My name is Margarita Seeley, and I'm a mental health clinical specialist with the Community Connect program, Whole Person Care. I was privileged to be on the AOD Alcohol Other Drug Disorder team, and we visited 5 sites to observe what was happening in those facilities and to see how alcohol and other drugs integration of mental health could be improved. We visited Discovery House, which is a residential treatment center for men, Psychiatric Emergency Services, Central Adult Behavioral, Miller Wellness Center, and Concord Homeless Shelter. One thing we learned that homelessness and drug abuse are very much connected. A lot of people turn to drugs when they're homeless just to cope with their situation. Some of the quotes that the men made at the Discovery House were, "Being homeless is the hardest thing in the world. Everything feels illegal when you are homeless. Just to eat, drink, water, and use a restroom." And if one of the positive things that was said by one of the men at Discovery House is, if you're willing to put in the effort, it will be available. Thank you.
Good morning. My name is Darren Webb, and I am a substance use counselor at the Behavioral Health Access Line, and I also had the privilege of serving as the team lead for the Alcohol and Other Drugs team on this week. After we did some of our observations, one of the things that we were noticing was that there was a disconnect between getting people connected to services within various mental health settings. One of those settings was PES, and what we noticed was that there was a serious issue with getting people connected in a timely manner to PES upon discharge. And so one of the things that we tested out this week was having an embedded alcohol and other drug counselor at PES who was able to refer directly into services. And that was successful. On this week, I was able to screen an individual and get them referred directly into services while at PES within 2 hours with transportation included into a treatment facility. One of our other observations was that within the clinics, that there was low amounts of referrals, and we found out that a lot of the clinicians stated that they were not actually making the referrals to the alcohol and other drug counselors within their own clinics just because of the paper referrals being lengthy, and that hindered them from actually filling out the forms and getting it over to the counselor. And that meant that that was a disconnect with the person who needed those services not getting those services. So one of the things that we tested this week was condensing the referral process. Instead of going on a paper format, we tested it out for that the referral could be in electronic format, and we tested that out, and that also was successful on this week.
Hi, I'm Jessica Johnson, and I'm a lead clinician at East County Adult Mental Health, and I had the pleasure of being on the scheduling team this week. And so two of the problems that we noticed were that their scheduling is fractured and it's not standardized. And in some cases, it wasn't electronic. In some of the clinics we went to, they had very large paper calendars that they were using to schedule nurses, clinicians, and such forth. And then those people had to be put back into the electronic health system, CC Link, which is our electronic health record here at the county. And this was causing lots of unnecessary waste. One of our goals for the week were to allow trained staff to schedule appointments directly into CC Link, to standardize scheduling processes, and to eliminate that paper scheduling and unnecessary steps, to make schedules clear and transparent across the system. Thank you.
Hi, I'm Brittany Curran. I'm a mental health clinician at the Forensic Mental Health Department. I was also part of the scheduling team this week. The first problem that we tried to address was that only the access line staff could schedule appointments at the clinic. The reason we found this to be a problem was that we have trained clinicians around the county that have the job of connecting or reconnecting people to mental health services. So you heard the example of psychiatric emergency services or detention. Before this week, they would have to either call the access line with the client or ask the client to call themselves and to get an appointment at a clinic. We felt that it would create a lot of frustration for the client, and it also was just unnecessary steps. So the result was we just went into the system to see if we could give access to, or well, what we wanted to test was whether or not we could actually do that. So we went into the system to see if we could give trained staff access to make those scheduled at clinic and establish a workflow and training tools for scheduling new clients. And so we just went into the system and we saw that we could, and we gave scheduling access to the mental health clinicians at those clinics, West, East, and Central. We gave it to detention, the forensics department, transition team, psychiatric emergency services, Miller Wellness Center, and the discharge planners at the inpatient unit on 4C.
Good morning. My name is Audrey McLemore. I'm the discharge planner at Contra Costa Regional Medical Center and 4C. So as a discharge planner, I am responsible for making sure that patients receive an appointment once they leave out of the hospital. So I have to call 3 regions, whichever site that that person lives in, and contact someone. And the majority of the time, I'm unable to speak with that contact person. So then I have to think out of the box, how am I going to get this person this appointment before they leave? So I begin to ask for several different people. And so I speak with someone and get the appointment resolved. But then I say in my mind, I said, this is so unacceptable, that I have to go through all those channels, calling names out, going up the chain. But the appointment would be given, but I feel that that's so unacceptable. So as being a participant all this week, we went out and we talked to different sites and let them know what we were doing, what we were thinking about, what we like to do, and what changes that we would like to be able to service our patients and, and to help everybody else. So the end result is, as of Monday, I will be able to go to CC Link and schedule a patient appointment without even having to call anyone. Thank you.
Hello, my name is Betsy Orem. I'm the program manager for the Behavioral Health Transition Team, and I'm also on the scheduling team. What we were focused on, and this piece is on clinicians, especially those that work in the field. So the current system really asks the clinicians to have people on their schedule in Epic before they see a client. So in order to do that, they had to contact their clerk and have the clerk put the person on their schedule. They couldn't do it themselves. This seemed like an unnecessary barrier and a burden, and for the staff and for the clerk. So what we were testing is whether or not we could give clinicians the ability to schedule their own appointments. And I think for clinicians in particular, a lot of times their appointments don't quite work out the way they're planned. They go to the field, the person's not there, but somebody else is there they can see instead, so they want to see that person, and they're not on the schedule, so they got to call the clerk and get them on. Anyway, it was a complete waste of time. So now we have created a system for the clinicians to schedule their own appointments. They can change it as the day goes on if it evolves. And the other sort of additional safety feature is that now we actually know where our clinicians are, not sort of where they intended to be. So I can look on their schedule and see exactly who they're seeing. So that's a real benefit. So we're excited to see this go forward. Thank you.
Hello, I'm Chris Farnatano. I'm your county health officer. I also had the privilege this week to be the lead on the scheduling team, our awesome scheduling team. And another test we did was streamlining some of the process of scheduling patients for return appointments with their psychiatrist. So currently, when the psychiatrist finishes seeing a patient, he has this little piece of paper. They call it a triplicate form. It really is in triplicate. And he hand writes on this form when he wants to see the client back. And then the patient is asked to carry this form up to the registration desk in the waiting room, and then the registration clerk has to kind of decipher the psychiatrist's handwriting. As a physician, I know our handwriting is not always so great, and then figure out when the patient should be scheduled back. We converted this to an electronic system in the electronic health record, where there's a follow-up section in the visit. The psychiatrist puts in when he wants to see the client back. That immediately pops up on the registration clerk's screen, so they see immediately when to schedule the patient back. Patient leaves with their after-visit summary that has their future appointment scheduled, and we've eliminated the paper form.
Hello, my name is Iris Holland. I'm a CC-Link application analyst with Contra Costa County. One of my primary focuses of specialty is for Cadence, which is our scheduling application. Several quotes that stood out for us this week from clinicians were, why do we have to go through the access line? A different clinician stated that it would be great if they were able to schedule their own appointments. And a third person said, let's eliminate the middleman.
Good morning. I'm Chad Pierce and the program manager for West County Child and Adolescent Behavioral Health Clinic. This week, I have the opportunity to be on the education team. One of the problems that we discovered from previous value stream mapping and rapid improvement events is that there is a real lack of clarity about the behavioral health division services and also how to access those services. As a result, some of the questions were, where do I access? Are there drop-in appointments? What are AOD services? Who or what is the access line? What should I expect? How long will all of this take? As a result of this lack of clarity, we created an easily accessible and patient-friendly video that will describe more clearly our services in a patient-friendly way. It is our hope that this video will be seen on our website, Twitter, Facebook, and throughout our health clinics. Now you'll see a short clip of the video.
Hi, so my name is Paul Juranovich, and I'm a licensed marriage and family therapist, and I work for the Behavioral Health Access Line in Contra Costa County. So what is the Behavioral Health Access Line? The Behavioral Health Access Line is the entry point for residents of Contra Costa County who are interested in getting services for mental health and for substance use treatment.
Hi, I'm Sophia Chen, a primary care physician and geriatrician or older person doctor for the Memory Clinic in Martinez. I see behavioral issues on a different realm as related to dementia, but also as a primary care doctor, I have to spend anywhere between 1 to 10 minutes, depending on the patient, in my 15-minute visit explaining the behavioral health process in general. By the time patients get to me, they're motivated and they've taken great lengths of bravery to get to know they want to seek services. I don't want the next step to be where they're confused or there's any barrier to them actually seeking services. So, as you have just literally seen, we focused our efforts in this team on media production. Video, we found, was the most approachable and easy to understand modality for not only sharing that kind of information in a broader sense to the public, but more importantly, to set their expectations of the current state of our behavioral health system. As you've heard, while my colleagues work on trying to rapidly improve the process and the experience of connecting Contra Costa denizens to the behavioral health services, we need in part to give everyone understanding of the process to better access care. So we went to each department within behavioral health and had the actual staff that clients would encounter explain the process to them. In our first test of change, we obtained qualitative feedback from key stakeholders. This means clients and their families, and as you've heard, that may mean one person is both. And we found that the video was helpful for them in understanding. And so we aim to continue on and place the series of videos on the behavioral health website, and as you've heard my teammate Chad say, on various social media sites as well. That way we can be able to get quantitative statistics back and monitor this on an ongoing basis. We partner with the Community Education and Information Office, who helped us in the first round of editing. And it doesn't have to stop there. As we've heard, there's confusion amongst staff as well. So in order to demystify and systemize this system, we hope to make this, this video out for the staff as well, so that we're all on the same pages, plural. Thank you.
Good morning, my name is Noelia Gutierrez. I'm an Administrative Services Assistant, and I had the opportunity to support the team this week. During this week, we collected a lot of quotes from staff, clients, and members of our community, and here are a few of the most impactful quotes. I'm thankful for not being on the streets. I can think properly and not focus on the negative. I wish I knew how long the call was going to take, and we need to enrich lives, not manage them. Thank you.
Good morning, my name is Barbara Hill Howard. I worked on the education team this week. I am a substance use counselor in the alcohol and other drugs substance use outpatient treatment at the West County Adult Mental Health Clinic. My understanding of teamwork was broadened this week. Processing the work of behavioral health from the perspective of the administration workers, the direct service workers such as myself, the phone contact only workers, the hospital workers, resulted in a heightened awareness that there are no big I's or little U's. Our positions are equally important in providing services to and for the community. Some of the quotes that we gleaned from the week to take back to our desks are, "Come on, damn it, we got too much at stake." People don't care how much you know until they know how much we care. To trust joyously that even though we are integrating the electronic health record system with patient services, we can still be patient-centered and compassionate. And it worked. We got a patient in. This is my pivotal moment for the week, reminding us to celebrate our successes rather than focus on that other stuff. Thank you.
Hi, my name is Tommy from Miller Wellness Center. Great to see you guys. One thing that was evident to me, a big theme that popped out, was that our system as it is right now forces our staff to come up with creative ways to be heroes for their patients and the people they care about. When we were interviewing staff, we would hear things over and over again like, "Don't write this down that I do this. I'm telling you this, but I'm probably gonna get in trouble because of how I do it." And I mean, you know, even as a manager, I can think back not too long ago as a case manager, doing those things because I cared for my patients. So what we're excited about on Monday is creating a system that makes it easier for staff to be heroes for our suffering community. Some of the amazing stuff that we're gonna do is to schedule and screen people outside of the access line, something I'm super excited about at Miller Wellness Center for sure. having alcohol and drug counselors and access line clinicians at PES, 4C, and Miller Wellness Center. We learned today that we can rotate them around. The need is such that we can have them moving back and forth between those sites to get appointments. Train more staff to schedule appointments directly into CC Link as opposed to having to call the access line, even though you're a staff who knows your patient and knows where they fit. Making education video available in a variety of settings, maybe even at libraries and different community places that we kind of congregate. Same-day access to services, which as a case manager at an old big clinic is just so exciting and mind-blowing. Field-based access line staff. What if someone called the access line and someone came out to them wherever they were to do the access line work instead of talking on a telephone? How much more of a connection would that make? And also the rollout of the alcohol and other drug referral, which is so exciting to have an electronic referral instead of a paper one. The staff at the clinic said, okay, we can do it electronically, but can we still print it out? And we were like, no, it's just gonna be in the system, too bad. So we're excited for Monday.
Hello, I'm Jessica again. So one of the things that we do following a rapid improvement event, such as this one, is the team gets together and creates a 30, 60, 90-day target sheet for what we would like to work on and focus on. So some of the so that we keep the momentum going from this wonderful week that we had. So in the next few weeks, the team will be implementing these target sheets on some of the wonderful ideas that Tommy talked about. And one of the quotes that we came up with this week was, "No act of kindness, no matter how small, is ever wasted." Thank you.
Thank you, everyone. And first, I'd like to sort of say congratulations. I'm Karen Schlein, sorry, Assistant Director of Quality and Population Health for the Contra Costa Health Plan. I was also workshop leader this week, and I'm just so proud of everyone. I'm kind of overwhelmed. So I'd just like to say congratulations to the team and thank you for all of your work. I'd also like to recognize many of the individuals without whom this work would not have been possible. All of the sites that we visited, that is where the work happened. You opened your doors and welcomed everybody, so thank you. I'd also like to say thank you to Emergency Medical Services. They let us use their beautiful brand new conference room, and it was really a pleasure to come back there every day and to get our work done in a modern, clean space. I'd like to say thank you to NAMI for your partnership. I'd also like to recognize that we have a leadership advisory. Some of you may not know that we have a group of county and community leaders who come together every evening after we've done our work to provide us with support, feedback, encouragement. And it's a really important and unique part of this process. And so thank you to everybody who served on the leadership advisory. In particular, I'd like to call out Anna Roth and Dr. Matt White, the executive sponsors for this work. We all feel really privileged to work in a place that allows us to take a week out of our regular jobs and think big like this, so thank you very much. I'd also like to say a personal thanks to Chris Farnatano and Erica Jensen. They have been the ones that have previously led these workshops, and they handed the baton over to me and to Amanda and provided us with great encouragement, feedback, and support, and so thank you both for this wonderful opportunity. And last but not least, clients and family members. This work is for you, it's about you, and we couldn't do it without you, so thank you for your support. I'd like to now introduce Anna Roth, the Health Services Director.
Gosh, you guys, sometimes I think about what I'm going to say, and then sometimes I just can't think of what I'm going to say because I'm so overwhelmed by the report out, and this is sort of one of those weeks. First, I want to thank the team. I know what the people in the audience and watching maybe don't know is the team members come from all over the county and the community, and I don't know what time they wake up in the morning, but I think it's like about 4:15, and then they end the day every day maybe about midnight, and I think there's some food in the middle there, and there's lots of questioning and introspection, but they work really hard during the week, and so I want to just acknowledge, I hope there's a long, restful weekend waiting for you all. I want to acknowledge all your hard work, your long hours, so thank you to the team. Please give them a hand. I want to sort of start with some recognition of logistics, and Karen mentioned that Chris and Erica passed the baton this week. For me, this was a really special sort of thing to witness, to see. I love to see improvement capability sort of spreading and leadership of improvement spreading across the organization. It's very special. And it was, I want to say two things about that. It seemed really seamless. And that's really a testament to Erica and Chris, and to Amanda and Karen, and to this really capable and willing team. So it really felt, for me, so great to see just kind of how seamless that went. It's a big deal. And so I want to just thank Chris and Erica for taking the time to shepherd people through, and then for Karen and Amanda to have the guts to get out there and do it. And you did a beautiful job. So thank you so much. So I wanted to think about what I was going to say, but I couldn't get past the quotes. This was sort of different this week. I think you guys actually packed this report out with quotes, which was really powerful. And I wanted to just pull a couple. I pulled some of the pages that had quotes, but I just want to pull a couple of them and that stood out to me. And one of them was that waiting creates suffering. And I think that you guys really took on waiting and delays in our system. I saw that. We saw the data, and I know the leadership team at the end of the second day, we brought the data to you so you could see those data around the waiting. But I think that what I saw is that quote drove a lot of work for this week. And that was one of the quotes you came upon the first couple of days. I loved the quote that somebody said, "We're here to enrich lives, not manage them." I thought that was really, and it was that kind of, I think that was, again, Darlene told us on the first day, this is about trust, right? We don't need to manage people, we need to walk with them. And that took me to our mission, which I love our mission, which is really convenient since I run the organization, but I've always loved our mission. I tell the story that I started here in 1993, and it really, aside from my children, working here has been the longest, most enduring love affair I've ever had, and it's because of the mission, and it's because of the last sentence of the mission. And it says, with special attention to those most vulnerable. That is our purpose. That is why we exist. We are the safety net. And what I appreciate so much about this team this week is you walk to the center of the mission. It was really hard for me, and I've actually kind of tried to work this up because I don't want to take Erica's baton and get teary right now, but when I read at the beginning of the week, we make predictions, and Dr. White said, I predict, he goes, oh, wait, I forgot to tell you one more prediction. I predict Erica will cry at least 3 times this week. Because Erica, I love working with Erica because she feels it so much. But the quote where somebody said, everything feels illegal. Eating, just drinking water. That is really an important message for us to hear. And we can undo that. We can make a difference in that if we meet people where they are and we stand with them instead of doing things for them. But that was really powerful. I love how somebody said, I wanted to find this, okay. When the person said, I'm looking, they rushed in and they showed me love. Somebody said that, I can't find it in the quote, but it's in there, it's in there. He said they all came rushing and showed me love. It made me think about the Avidus Donabedian. He is a physician and one of the founders of Quality Improvement in Healthcare. And what he said about quality is that quality, the secret to quality in healthcare is love. And that if you have love, you can work backwards to improve the system. And that's what you guys did this week. You worked backwards and you improved the system. You worked forward, it took us forward. But also you went to the center, to the mission where the people are, and you improved our system. And for that, I'm so grateful, and I'm really excited to see what happens next. So thank you so much for all the work you've done. Please let me know if there's anything that I can do to make sure that the work continues to move forward, and there's anything we can do in our system to accelerate your work, because we are with you 100%, and we will improve our system. So thank you so much. Thanks.